Now, how to make a diagnosis of a breast cancer and how to strengthen your diagnosis or make a definitive diagnosis in case of the breast cancers. So one thing you need to remember is a triple assessment. So triple assessment is actually comprising of clinical, which comprise of history and clinical examination. Then you have a part of the imaging, which is the radiographic imaging. And then you have a part which is called as the FNAC or core biopsy. So in clinical data, you have to ask about the age, the history, all important things in the history, the geographical history, the family history, the history of exposure to the radiation, the history of use of the OCPs, and any history of cancers like uterine, ovarian, or breast cancers in the family. The clinical examination is also part of the triple assessment, in which you have to follow a proper protocol and you have to examine the breast in 3 different positions, which is in a sitting position, in the lying position, and in a position in which you have to ask the patient to abduct your arms like that, and you have to ask the patient to support his head like this and in a supine position, so that obviously the pectoralis major will be contracted and the breast tissue is lying over the clavipectoral fascia. So any lesion in the breast tissue, that would be more pronounced. And then you have to palpate circumferentially, and you have to palpate in a radial directions as well, and you have to locate for any axillary lymph nodal metastasis as well. Then there is a part of triple assessment which is called as imaging, which is the radiographic imaging, and you have 2 important modalities, which is the ultrasonography and the mammography. So remember, in case of the young population, you have to go for ultrasonography. If the age of the patient is less than 40 years, then you have to go for ultrasonography. And if the patient is above 40 years, then you have to go for mammography. Why this demarcation is there? Because in a postmenopausal woman around the age of the 40 years, the density of the density is changed. So because of the change in the density, the lesions cannot be picked up by the ultrasound. So you have to go for mammography. Remember, age less than 40, go for ultrasonography. Age greater than 40, go for mammography. And then there is another part of the triple assessment, which is the pathology. And you go for fine needle aspiration cytology, or you go for the core cut biopsy. So what's the difference between fine needle aspiration cytology and a core cut biopsy? So in an FNAC, what you do that you just have to take an FNAC needle and then all the way you puncture the lesion and you take the cells for cytology. And in a core cut biopsy, you take the tissue deeper from the lesion by making a small incision in the area where you can palpate the lesion, and then all the way you can take multiple chunks, multiple samples, almost 5 to 6 chunks are enough of the good length, and then you send it for cytology and histopathology, in which you can see there is a invasive ductal carcinoma or globular carcinoma. So for good histopathological finding, you have to go for a core cut biopsy. So clinical imaging and pathology, they makes a part of a triple assessment, and you have to do in all the patients. Now, when you talk about the clinical features, there can be discharge from the nipple, there can be, a venous congestion as well, there can be recesses, there can be redness, hot skin, and swelling. Why there would be redness? Especially in case of the cancers which are inflammatory cancers. Or there can be retraction of the breast nipple, there can be asymmetrical breast, one size of the breast is different from the other when you do the comparison, or there can be a sealing tumor, a very small tumor which cannot be palpated, or there can be a retraction of the skin, which is called as the nipple retraction as well, or there can be in advanced stages like stage 4 cancers, there can be fungating masses with ulceration and obviously this is a very poor condition, and then you have to go for a toilet mastectomy, and then there can be pulling or puckering of the skin under the tumor. I'm not going to talk about this in detail because I've already covered in the previous lecture. So these are the clinical features you have to look for, and you have to ask your patient. Now, regarding the imaging, you have one technology or the modality is the mammography, and other is ultrasonography, and in some extensive cases in which you cannot pick up the tumor from ultrasonography and mammography. Then you have to go for magnetic resonance imaging. Okay, so you can see this is a picture of a mammograph. So this is actually the breast tissue. You can see the densely populated, or you can say a higher density of the breast tissue, and there is a microcalcification here. So that's how by the mammography you can pick up the high densities lesions, or you can pick up the microcalcifications. And there's another tumor you can see here. The rest of the breast tissue is normal, but there's a hyperdense lesion here just close to the nipple areolar complex. So this is also indicating the breast cancer. And then you have the ultrasonography as well. So you can see that this is actually the part of the mass which is hypodense as compared to the rest. So in mammography, the lesion would be hyperdense, but in ultrasonography, the lesion or mass would be hypodense as compared to the rest of the parenchymal tissue. So you can see here as well. So this is actually the normal breast tissue with the ducts, you can say, but these darker areas, they show a lesion in a breast. And there is other modality which is called as MRI. MRI is a very sensitive modality, and it picks up the microcalcifications very easily. So you can see here, this is the two of the breasts are being examined. So you can see there are multiple smaller lesions. Maybe these are not picked up by ultrasonography and mammography, and then you do the MRI. So these are multiple lesions, and you can pick up the hyperdense microcalcified lesions. And microcalcification and macrocalcification is important because usually in benign tumors there's a macrocalcification, but in the malignant tumors there's a microcalcification. So that's why microcalcification is important to pick up, even if you do with a mammography, ultrasonography, or mammography, or you do the magnetic resonance imaging. And some other diagnostic procedures, definitely the definite histopathology. For the clear picture and to plan surgery accordingly is the biopsy. Okay, you do the fine needle aspiration cytology, or you do the core cut biopsy. But FNSA is it's still not more acceptable as compared. It's not better than core cut biopsy. So you have to do the true cut or core cut biopsy. We have biopsy needle, and you take multiple chunks, and then you go for histopathology, and then you go for radical mastectomy, or again you go for axillary. Obviously that would be the ultrasound of the axilla is very much important as well, because you're going to look for the nodal status as well, because you're going to go for axillary clearance as well, level 1, level 2, or level 3, depending upon how much of the lymph nodes have been metastasized. And then you can also go for the biomarkers, which are not very much significant in case of the CA breast. But remember, CA 125 is the tumor marker for the breast. So triple assessment is important. Clinical, physical examination, history make us the clinical part. Then you go for the imaging, in which ultrasonography, mammography, and magnetic resonance imaging, and then the pathology, the core cut biopsy, fine needle aspiration cytology, and some of the tumor markers. They can have the good good response, and then you can identify if the tumor is invasive or not invasive. And then by the help of this biopsy as well, sometimes you can go for hormonal status as well. If the patient would be needing a hormonal therapy, you go for estrogen receptor positive, estrogen, progesterone receptors, and HER2 receptors. So a cord cut biopsy, obviously that would be, FNAC would not give you this information. So cord cut biopsy is very important and much better as compared to the FNAC.